Okay, so hello everyone. My name is Ziv. I'm from Tel Aviv, Israel. And today I'm going to talk to you a little bit about a recent work we've done about neuroanatomical risk factors for PTSD, which is post-traumatic stress disorder. And yeah, let's get going. So I'll start from the end. If I want you to take one sentence from my short presentation today, it will be the following one. We found that smaller volume of the hippocampus together with enlarged neurodevelopmental abnormality called septum pellucidum, right over here, together is associated with more symptoms of post-traumatic stress disorder, both acute PTSD and chronic PTSD. So now I'm going to start from the beginning and try to explain to you how we got to this conclusion. So, although there has been a lot of neuroimaging works and studies about PTSD and also some abnormalities that were discovered in relation to PTSD, we are still missing reliable neural markers of this disorder, which can estimate actually the risk of developing PTSD, could differentiate between a person which will develop the disorder or which will heal by itself. Why it's so important? It's so important because these markers or anatomical signatures could help us, first of all, identify those at risk, provide accurate diagnosis, and also help us with early intervention in order to reduce the likelihood of developing PTSD. So far from all the studies that I've mentioned, the most replicated and straightforward finding was lower hippocampal volume in PTSD patients. However, it's still not clear whether it serves as a risk factor, that is, smaller hippocampus exists even before the trauma and then cause to PTSD, or it is a result of trauma. It's probably a combination of both of these explanations. And one alternative can say that the hippocampus is not the only measure, not the only abnormality in PTSD, but it's more complicated, and it could be an interaction or combination between the hippocampus and some other brain anomaly, possibly one that is developmental one that changes as we grow up. So an example for such anomaly that I'm not sure that everybody is familiar with, so I'm going to explain a little bit, is called septum pellucidum. Some of you might heard it as the fifth ventricle, which is kind of inaccurate, but sometimes it's called like that. So basically in normal development, the septum pellucidum, which separates between the two lateral ventricles, after 3 or 6 months of age, it fuses together and then it creates the septum pellucidum that separates between the ventricle, as I said. But for some individuals, it's unclear why, the two leaves of the septum pellucidum sometimes they not fuse completely, thereby they're leaving a small cleft or a cave, which is filled with CSF, as you can see here. And this is called the septum pellucidum. It's like a cleft filled with cerebrospinal fluid, CSF, and it's just an abnormality which doesn't have a lot of clinical implications so far. There has been some research about CSP, like I said, the fifth ventricle. Even in the last 20, 30 years, few studies. They're mostly linked abnormal large CSP to schizophrenia and to bipolar disorders, some other psychological disorders, but nothing too conclusive. And however, regarding PTSD, like what I'm going to demonstrate today, there's been only 2 studies which try to examine the relationship between CSP and PTSD, suggesting slightly that it might serve as a vulnerability factor for PTSD. That is, whoever has this abnormality, the CSP, is more likely to develop post-traumatic stress disorder. So what we did here is we tested the relationship between CSP volume, hippocampus volume, and PTSD symptoms in a large cohort of recent trauma survivors. We hypothesized, first of all, that the CSP volume, as it will be larger, and as the hippocampal volume would be lower, it would be associated with more PTSD symptoms. All of that, we're talking about 1 month after trauma, so very early afterwards. Moreover, our secondary hypothesis was that this early neuroanatomical signature of both hippocampus and CSP could also predict symptoms 6 months and 14 months after the event, which is even more important because as some of you may know, a lot of people experience a lot of symptoms month after trauma, but then they start to recover, some partially recover, and some stay with PTSD, unfortunately. So, briefly what we did, this results I'm showing you today is part of a larger study that if you're interested, you can read in the study protocol that was published. Basically, we examined trauma survivors, so people that arrived to the emergency room of the hospital after a traumatic event, mostly car accidents, but also been sexual assaults or terror attacks. We contacted them after 2 weeks via phone, and we invited them to our lab 1 month after the trauma to do both clinical assessment, clinical interviews, and neural assessment using MRI and functional MRI. And the work described here, we're talking about 171 individuals like that. That's a big portion, 97 of them, and 78 returned for follow-up clinical assessment at 6 months and 14 months after the trauma. So the clinical assessments were based on a clinical interview using the CAPS, which is the gold standard of PTSD diagnosis based on the DSM, and the neural assessment, we used high-resolution MRI scans analyzed by FreeSurfer, and in the end, we're interested in both hippocampus and CSP presence and volume. And moreover, in addition to the automatic assessment by FreeSurfer, we also did a manual assessment of the CSP, the fifth ventricle. We had a neuroradiologist, which was blinded to the participants' clinical situation, clinical symptoms, and she also tried to manually verify if the CSP, as measured by the software, was actually the CSP, as a neuroradiologist could see it. And hence, there was 28 participants who had a mismatch between the neuroradiologist and the software, and we excluded them from this analysis, making it harder for us to get an effect. But still, if we look at the results focusing on the first time point here, just 1 month after trauma, we can see in the table on your left side, it's a summary of the regression, which we try to predict PTSD symptoms by using hippocampus volume, CSP volume, and the interaction between them, and also with covariate of age, gender, trauma type, and intracranial volume, ICV. And as you can see, hippocampus itself and CSP itself contributed, but did not significantly predict PTSD symptoms. Nevertheless, we see a significant interaction, moderation effect. So what this means, it means that the combination of the two, I'll put this, it'll be easier, the combination of the two, meaning higher, presence of CSP of this abnormality and larger volume, together with lower hippocampal volume, contributed to PTSD symptoms 1 month after trauma. If you look here in the interaction, just for illustration purposes, so we have 3 continuous variables, but we took the hippocampus and divided it to 3 values, low, median, and high. And as you can see in the red line, only for individuals with low hippocampus, you can see a positive significant correlation between CSP volume and PTSD symptom severity. Moving on to the second hypothesis, we wanted to check if this early anatomical signature of CSP and hippocampus can predict symptoms 6 months and 14 months later. So in the second time point, we didn't find any significant interaction, but 14 months after, which is 1 year, more than 1 year after they were first measured, we see again a very significant correlation. So each anatomical measure by itself almost didn't contribute at all for predicting the symptoms, but again, the correlation between them in the same direction, higher CSP volume, lower hippocampal volume, both of them measured 1 month after trauma could predict if the person would develop PTSD and how severe it will be after 1 year. So just to conclude, I present here quite a simple to acquire neuroanatomical signature, which I showed you that can be associated with the likelihood of both early PTSD symptoms and persistent PTSD symptoms after trauma. We used here a longitudinal approach that combined clinical and neural measurements, a large cohort of 171 people, which also allowed us to have enough people with CSP to measure, and automatic and manual CSP validation or assessment that could identify it easier. The bottom line, as MRI nowadays is becoming more available, both in the emergency room and trauma centers, we think that with a very simple, easy test, we could identify individuals at risk using this two areas that I've talked about, and those could benefit from early intervention. And we can also follow up their clinical condition in an objective manner and not only based on the symptoms. So I want to thank all the people, a lot of people working in this project, especially the research team. And if you're interested in more details, I encourage you to, first of all, read the paper recently published in Biological Psychiatry, and to come see my poster number 3 tomorrow. Yeah, thank you.